Good evening, everyone, and welcome to our hormone therapy update webinar this evening. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I would also like to pay my respects to elders past and present. Welcome, everybody, to today's webinar event, and thank you for attending. Majority of our webinars are recorded and freely available on our PHN Learn YouTube channel. We have a practice communique we send out to all practices fortnightly with valuable information, including an external calendar of events and internal calendar of events. You can also find all of our latest education on our website and a few upcoming events highlighted on this slide. Please pay particular attention to our upcoming Primary Care Refresher Conference. This is a two-day virtual event with concurrent GP and primary care streams, and this year's theme is Partners in Prevention. You will hear from the Department of Health, Professor Michael Kidd and Alison McMillan, alongside a long list of renowned health professionals. I will put a link to the event and detailed program in the chat. During this evening's webinar, participants will remain on mute. If you have any questions, please type them in the questions box. We will ask the questions on your behalf anonymously during question and answer breaks. Our presenter for this evening is Dr. Sonia Davison, Jean Hale's endocrinologist. We will go directly to Sonia after a brief health pathways update from Kate Graham. Please make note of the Westvic PHN health pathway relating to this evening's webinar topic. This is on the screen at the moment. There is a flyer in the handout sections for you to download which contains this information and the login details. Kate, I will now hand over to you to talk to this slide in more detail, and then we will go directly to Sonia. Thanks, Kate.
Thank you. So Health Pathways, for those of you that aren't familiar, it's an online clinical platform for primary care clinicians that contains condition-based guidelines and local referral information. I'm one of the Health Pathways program clinical editors at Westvic PHN. So the pathways are all written by clinical editors in collaboration with specialist subject matter experts, peak bodies and agencies according to the best evidence and in consideration of the local context. So on the slide and screens, a sample of the pathways relevant to this evening's content. We've got a really large suite of women's health pathways relevant to just an array of conditions that we've developed with local obstetricians and gynecologists. And the menopause pathway in particular was developed with the assistance of the Jean Hales Foundation clinicians. We're currently expanding our suite of pathways relating to vulval skin conditions and reviewing our pathways on sexually transmitted diseases. So Health Pathways now has approximately 850 clinical, referral and resource pathways available, and I'd really encourage you all to log in. The content's only available to clinicians in Western Victoria, and the login details are up there. So with that, I'll hand back to Sonia and enjoy the evening. Thank you for your time.
Thanks so much for asking me to speak again, and I'm delighted to be with you speaking about menopausal hormone therapy and trying to update you as to where we stand now with hormone therapy, which was a lot different to where we stood maybe 10, 20 years ago. So there's been a little bit of an upheaval in that time. I'll just go through what menopause is again. It's actually the last menstrual period. It gets a little bit clouded if women are on the pill, for example, up until 50 and periods don't ever happen again, or if a Mirena is in situ, or endometrial ablation, etc. So those ladies are a little bit difficult, but it's actually just the last egg and the last period. Natural menopause is what we'll all go through if we get to the age of 51 to 52 in Australia, and that hasn't changed in a long time. Surgical menopause is when both ovaries are removed for endometriosis or cancer treatment or whatever, and that will render someone instantly menopausal, possibly at a young age. So ovulation stops. It's a little bit sad about fertility, but for others it's a blessed relief from periods, etc. and we lose the cyclical production of estrogen and progesterone. Premature menopause is a very important subset here because this is menopause before the age of 40 years. And this is important because women are designed to have a certain amount of estrogen up until about 50. So you can think that some women will be premature menopause even in their 20s, and they are meant to have estrogen. And it's very important, if they're allowed to be on some form of estrogen, be it the pill or hormone therapy, for bone protection, for heart disease protection, and for cognition protection as well. So that's a very important subset of the menopausal. Rare, but you will come across a case or so of those. So I thought this was very useful to break down the symptoms around menopause, and women will be coming to you for other health issues and for health checks, etc. And you are their trusted source of information and advice. Believe it or not, it's not Dr. Google and all those other things. When we do surveys about this, it's actually health practitioners, and in particular, they like sitting with a doctor or nurse health practitioner. So these are the groups of symptoms, and not every woman will have all of them, and not every woman will have any of them. So it's very variable. So you'll see on the left the vasomotor symptoms: flushes, sweats, and feeling hot. Some call it like Vesuvius. Some drench beach towels overnight, they sweat so much. The next ones are genitourinary, so vaginal dryness. Some may get a discharge and think they've got thrush, but it's actually vaginal atrophy after menopause. Dyspareunia, urinary frequency, leakage or urgency. Mood issues can happen, and these symptoms can start to happen from perimenopause, which is median age of about 46 or 47, when the signs and symptoms of approaching menopause start to happen because estrogen is dropping. So irritability, mood swings is another thing, teariness, anxiety and depression, and not just feeling themselves. So it's important to acknowledge this because hormone therapy can help some of these women as well. So then I've got the next column along here, the second to the right, somatic. So body symptoms. That first word there is formication, a feeling of ants crawling under the skin. It's a very strange sensation. It's associated with restless legs. It can drive some women quite mad. They feel it's a very difficult symptom to get away from. Muscle and joint aches and pains. You might think that they've got some amazing sort of arthritis, but it's just menopause. Weight gain, especially around the tummy, headaches or migraine, and bloating. And the last things are very important. Sleep disturbance is this huge part of menopause and can drive, women can just sit up at 3 a.m. and just not go back to sleep. So that's the sort of menopausal witching hour, as I say it. Lowered concentration, fogginess, fatigue, and word finding difficulties. So these are the things you should be thinking about in women from their mid-40s onward, especially up to 55 or so. But some women, as you'll see, will have symptoms that go on for a lot longer than just that time around menopause. So I have this 20-20-20 rule. 20% of women have few or no symptoms and might not come to you for any sort of advice about menopause, but we still need to be doing the health checks, check the blood pressure, check diabetes, make sure they're having mammograms, cervical smears, etc. 20% have severe symptoms and can drench beach towels, can be suicidal, those sort of things, won't sleep at all, and they really need very close attention because they can be really in trouble. 20% have symptoms that go on for a long time, so even after 5 to 7 years, and they say, how long will my symptoms go on for? I've got some ladies in their 70s with symptoms that go on, so it's a long time. But 60% have 4 to 8 years of symptoms, which can decrease quality of life. And menopause is very much about decreasing quality of life. So I'll take you through Eva. Eva is 52 years of age. She's single, a social worker, and works full-time. She's presenting to you with low mood, anxiety, lethargy, and just doesn't sleep very well. She feels hot generally, but she also has symptoms at night. So one thing that will start to come through in perimenopause is the symptoms start to happen at night. Towards closer to menopause, the symptoms might happen more in the day. So drenching, sweats, and frequent flushes. Her periods stopped a year ago, were erratic for 12 months prior to that, and she's worried about her bone health because her mum has osteoporosis and has fractured her neck of femur. So what do we do in terms of managing EVA? We treat bothersome symptoms. Menopause is all about bother. It's about quality of life. It's about function. It's about being able to do the things a woman wants to do and should be able to do. So lifestyle measures are extremely important. Hormone therapy is one option. We used to call hormone replacement therapy, hormone therapy after menopause. We're now trying to call it MHT, or menopausal hormone therapy, because they argued that it wasn't actually really a replacement. I think it's difficult because the lay public know the term HRT, so I'm still using both, but I'm trying to use the MHT. Vaginal estrogen can be part of hormone therapy, and that can be a good measure for those who have genitourinary symptoms and not the other symptoms. But there's also non-hormonal medications and non-medical options to treat symptoms as well, and there's no one right solution. And most women will be frightened about having hormone therapy and will want to do the other options first. These are easy lifestyle measures, and they're probably doing them by the time they come to you, but overheating, dressing in breathable fabrics in layers, especially overnight, having appropriate sort of sleep attire and doonas, etc. Avoiding alcohol excess, that can make flushes worse, and spicy foods, and smoking. Smoking results in an earlier menopause in some women and more severe symptoms as well, and an increased risk of premature menopause. So you should tell that to your smokers if they're worried about fertility and their bone health, etc. Healthy diet and regular exercise. We know that when there's an increase in fat mass, that gives an increased added layer of insulation, and that can make flushes and sweats worse or more unbearable. And stress management. That will also have a flow-on effect with managing menopausal symptoms too. Easy to say, hard to do. So when we're looking at hormone therapy, these are the sort of the guts of it, as it will be. When we look at International Menopause Society consensus statements and guidelines from all around the world, it's very consistent that the benefits of hormone therapy far outweigh the small risks in healthy women around the time of perimenopause and menopause. So that's an important thing, and I do just outline that to some of my ladies just so they know the context of this, because many of them will just be thinking HRT equals breast cancer. There is an increased risk of breast cancer after 5 years of use, but the studies suggest that's a slight increase and not a major increase, and women should be aware of that too. Many trials support a safe window. So if you use hormone therapy around the time of menopause and not many years later, for example, from 70 plus when arteries are stiffer, initiating hormone therapy then, that's much safer and gives a cardiovascular benefit and other benefits. And we usually would initiate hormone therapy at age less than 60 years. You must remember that some women will have a menopause at age 57. It is normal from 45 to 55, but some will creep up to about 57. Or within 10 years of that last period. Younger women are much more likely to be symptomatic, have lower background risk for things like clots, stroke, heart disease, and they're more likely to get a cardiovascular benefit. So this is a lovely, what's termed a matrix. The US Endocrine Society got this together, looking at all the big studies, so it's not just one study, and looking at the risks and benefits for hormone therapy for women sort of in the target hormone therapy audience between 50 to 59 or within 10 years of menopause. The way that this graph works, you'll see the line in the middle here and the ones to the right here, and the black line is estrogen only, the white line is estrogen plus progestogen. You will see to the right of the slide there's a net benefit. So you'll see for flushes and for vaginal symptoms, there's a net benefit of both types of hormone therapy. And the risks are all down at the bottom there, the things like fractures, diabetes. So when there's a risk, it'll be on this side of the graph, on the left side of the graph. And you can see pretty clearly that with the risks, it's a blip in the radar, even though in women's minds, they might be amplifying those risks, depending on what they've seen in the media, etc. So this is also a nice slide to show women. You can get it from the internet pretty easily, to tell them about the risks and benefits. That overwhelmingly there's a benefit and the risks are a small, as I said, blip in the radar, but the next slide is an amplification of the bottom of the screen, and it's the same data. So when you amplify it out, it's a little bit different for estrogen only, which is the black bar in all of these lines, and the white one is the estrogen and progestogen. And you'll see some of the things clearly are on this side and some of the things are clearly on the left side. But you'll see it's very interesting. For both types of hormone therapy, there's a benefit for fracture prevention, diabetes too. I do not understand that, but they have less diabetes incidence. Breast cancer, the estrogen only is favoured, so that's a lesser risk, but you'll see there the white bar, there is an increased risk of breast cancer with combined estrogen and progestogen that goes on for more than 5 years, not really within that 5 years, we think. Colorectal cancer is very interesting. There's a benefit from estrogen and progestogen treatment together. Overall mortality, see there, both types of hormone therapy, there's a benefit for mortality and a benefit for heart disease. Really the outstanding risks down the bottom, cholecystitis, VTE and stroke, which is a very low incidence in this age group, and that's more with oral treatment. We'll talk about that in a minute. But that's also comforting for some women to have a look at that, especially if they're on estrogen only. So when we're prescribing hormone therapy, this is what you always do anyway, but make sure there's no contraindications. Hormonally sensitive cancers of any type, thrombophilia or past VTE that can't be easily explained and that a haematologist hasn't given the okay for hormone therapy, undiagnosed vaginal bleeding that hasn't been sorted out, acute liver disease or uncontrolled blood pressure, or cardiovascular disease or risk. Ensure their screening's up to date. You're really good at doing that as a group, and start with a mid-range dose. The studies sort of say you can start with a low dose, but I often think that that's not going to be very effective. The women have been used to being exposed to quite big amounts of estrogen throughout reproductive life, and they might abandon therapy because they think it's not working. So I always go with a mid-range dose, and then when I see them at 3 or 4 months, I titrate that up or down. And we're trying to use treatment for the shortest duration for bothersome symptom control or for bone health in some circumstances. And premature menopause, as you've heard before, is different. We want to push hormone therapy or some form of estrogen and progestogen if they need it till age 50, unless they can't because of cancer risks or whatever. So there's lots of different ways of giving hormone therapy, and it gets very complicated, and it's been a very difficult year because a lot of our patches have been unavailable over the last year, and a number of our tablets at different times as well. But low dose therapy has less impact on VTE risk and less impact on breast cancer. It's a dose response thing. Transdermal, again, less effect on VTE risk and stroke risk. Estrogen only, less effect on CVD risk and VTE risk, and less effect on breast cancer risk and colorectal cancer risk reduction. Not all progestogens are the same, and I'm going to go through that more, but the more natural type of progesterones like micronized progesterones and dihydrogesterone, which is very similar to the body's progesterone, have a lesser effect on breast cancer, and that's been seen in several studies, many studies actually to date. Bleeding is one key consideration, so that will lead you to a sequential or continuous regimen. I'm going to go through that more. Estrogen only or estrogen plus progestogen or localized, so vaginal estrogen. Risk factors, presenting symptoms will be important. Some will just have vaginal symptoms, some will have the whole lot. Need for contraception if they're perimenopausal. The costs will be important, PBS versus non-PBS. And premature menopause, the dose and duration. We do tend to want to use higher dose because their average estrogen would have been predicted to be higher until age 50 or so, and the duration, we do favour treatment if they're able to have hormones until age 50 at least. So if the women are recently postmenopausal or perimenopausal, there's a high risk that they'll bleed just because the womb is used to bleeding under the influence of hormones. So it's probably more useful to give them a sequential regimen of hormone therapy. So that means estrogen throughout the month, but progestogen usually for up to 2 weeks of the month, and they will have a withdrawal bleed after that that won't last for another 2 weeks. It should be just a light normal period. Bleeding is more frequent in the first 3 months of hormone therapy. You need to let women know because they might be freaked out by it, or when the hormone therapy dose is missed, even if that's a patch, and a patch being a day or half a day late. The progestogen for hormone therapy can be the levonorgestrel IUD. That's a very good option, and it's great for perimenopause. It's great for contraception. and it's great for women who have difficulties with bleeding. I really favour it. Continuous combined versus sequential. So if they're more than 12 months after menopause and they haven't had a bleed for some time, you can use continuous estrogen through the month and continuous progestogen throughout the month. We've talked about the sequential regimens. That's more if you think that they're really going to bleed, or if they're on hormone therapy and start bleeding, it's better to go to a sequential regimen. Do that for a year or so if they need hormone therapy that long, and then try continuous after that, because women do not usually want periods, although some are outliers and will prefer to have a period, and everyone's individual in all of this. If a lady has had a hysterectomy or has a levonorgestrel IUD in, she can certainly have just estrogen only hormone therapy. If they've had an endometrial ablation, you might argue, oh, there's no endometrium left, we don't need to protect it, but there might be isolated pockets of endometrium, so we always do need to add a progestogen to the estrogen if they've had an ablation. And some women, if they've had extensive endometriosis, even if they've had surgery or whatever, clearance surgery, we might add a progestogen back to them because we know the estrogen promotes the endometriosis growth, whereas the progestogen tends to dampen that dose down. So if they've had severe endometriosis, I'll usually offer them a progestogen again, which is tricky because, as you've seen from the previous slides, that's more or less where the breast cancer risk tends to lie. So it is a very difficult situation, and you need to just counsel the women in that situation. I am hoping to advance. All right, I have advanced. Let me just make sure that I can keep advancing. So we're looking at, I think I've advanced too many times now. So systemic hormone therapy versus vaginal hormone therapy. I'm so sorry, I do not know what's happening with my slide here. We've talked about that, keeping you on your toes. So systemic hormone therapy versus vaginal estrogen. If a woman only has vaginal or urinary symptoms, we use vaginal estrogen, and it's very safe for long-term use. The studies have shown no increase in cancer risk, but if they have had breast cancer, etc., you do need to clear it through their breast surgeon or their oncologist before you use vaginal estrogen. Systemic hormone therapy is useful for symptoms such as flushes, night sweats, sleep disturbance, joint aches and pains, so those body symptoms. But it will also be good for genitourinary symptoms, but it might just take a little while to kick in. So I will often, if symptoms are severe for the vaginal and urinary symptoms, I will often start both and then later on just withdraw the vaginal estrogen if they don't need it. Perimenopausal will potentially need contraception, and we've talked about sequential regimens and bleeding. We've talked about levonorgestrel IUD, which is a great option and can be in there for 5 years for contraception and up to even 7 years for endometrial protection for hormone therapy purposes. Continuous combined therapy is useful if they're absolutely postmenopausal and 1 or 2 years after bleeding. The types of hormone therapy, there is PBS versus non-PBS items, and that will be an issue for some of your ladies. Oral versus transdermal versus vaginal estrogen, and it gets trickier because there are combined products which have the estrogen and progestogen in them versus a combination of different estrogen and progestogen products and estrogen only. So it does get very complicated. You need to be telling ladies that hormone therapy is not contraceptive if they're aiming for use for contraception, and especially for premature menopause, some of those ladies will ovulate out of the blue, so you need to be very careful. It's funny having a discussion about contraception and menopause at the same time, but for those women, yes. There's a lovely information sheet on the Australasian Menopause Society, AMS website, about equivalent doses of hormone therapy. It's very useful, especially with product shortages. Recently, it will tell you what's on the PBS, what's not, what's low dose, what's an estrogen only, what's a combined product, and it's very useful. There's also a Jean Haas menopause information sheet, and I think I've got an image of that coming up later in the talk. So oral or transdermal, we're using a lot more transdermal hormone therapy, and maybe that's because women are having more metabolic issues. They're probably getting bigger in terms of obesity and overweight. But some women are definitely better suited to taking a tablet every day, and some are better suited to using transdermal hormone therapy. So oral hormone therapy, it's convenient, daily dosing, it's reliably absorbed. Some may have nausea and a bigger tendency for breast tenderness, fluid retention or weight gain due to it going through the liver, essentially. There's an increase in VTE risk, which is well described for oral hormone therapy, and especially oral estrogen, not as much oral micronized progesterone compared to the other progestogens. Transdermal, we have two types of gel now, one on the PBS, one not. Most patches are a twice weekly dosing, so I sort of say Monday morning and change it on Thursday evening to make it 3.5 days. There are weekly patches. Some women find them clunky and big and that they don't last the week and need to change them after 5 days. Some find they don't stick. It's a lower effective dose because it goes straight through the skin into the bloodstream, avoids the liver, and that's very useful for reducing metabolic risk factors. There's a lesser tendency for breast tenderness, weight gain, no increase in VTE risk from the studies. Some find the gel's a bit messy and hard to absorb. Some have local patch site irritation. So there's no one right way. You just start with a product you're aware of and you know it's available and that you're familiar with, and then you just see what happens in 3 months and then change it accordingly. There are lots of different progestogens. So the most widely available estrogen now, we used to use a lot of conjugated equine estrogens or Prometrium, but that was historical. We're now using mostly estradiol in this country, and that is exactly identical to the body's estrogen that the women made before menopause from their ovaries. So they can be comforted that when we're using an estrogen, most of the estrogens now are body identical, be it patch, tablet, vaginal, pessary, or whatever. But you'll see there that there's a lot of difference with the progestogens. And again, remember, we talked about breast cancer risk before. So you'll see item A there related to progesterone. Micronized progesterone is exactly identical to the ovaries progesterone, and we have that as an oral capsule that they take at night. It's very good for sleep and calming for mood, but they can use it vaginally if they need to. It's a little bit less data on that, and I wouldn't do that routinely, but you could use it if you needed to. Historically, we've used more of medroxyprogesterone acetate, sapropterin acetate, and dydrogesterone, which are related to pregnane. Dydrogesterone is very close to the body's progesterone, as is the bottom one on the right, drospirenone, which is a spironolactone derivative. It's quite good for some women, therefore, who have hirsutism, who might have scalp hair loss, or might be running with a higher blood pressure. So that might be a good option for them. And you'll see in item B there, norethistone acetate is a component of that combined patch that we have, and some oral preparations do have that as a progestogen as well. And of course, you've got the levonorgestrel related to testosterone in the middle there on the right. So Tibolone is a very unique compound. It's a very low dose hormone therapy. It's more a progesterone in nature, but it splits into 3 isomers. So one is estrogenic, one is progestogenic, so it will protect the womb lining, and one is like testosterone, so it can be good for mood, well-being and libido, but it's a weak effect and not in everybody. It's appropriate if they're more than a year post-menopause because they'll have bleeding issues otherwise potentially. It is synthetic, so it's not body identical, and that might be important to some women. It doesn't increase breast density, and at the cell level, it actually inhibits breast cancer growth. But when they did a study called Liberate in women who'd had breast cancer versus placebo, who had terrible menopausal symptoms, unfortunately, the women on Tibolone had a higher rate of breast cancer recurrence. So we don't recommend it after breast cancer, and we don't say that this is entirely safe for breast cancer purposes, but it is a low dose and a lesser risk than some forms of combined hormone therapy. It's a lesser VTE risk, so you might have some women who are high VTE risk who will be on this for that purpose. And I would consider it if they're not having many flushes and sweats, etc., or if they've got low libido. So I think that's a good option for these women, and it is very good for vaginal dryness. That's the other option as well. there is a slight increase in risk from the mid-60s, which you need to let women know about. Duaviv, it's a little bit of a moot point at the moment because it's difficult to obtain, but it's the concept of T-sec, which is very unique. This is a combination of an estrogen and an estrogen blocker rather than an estrogen and a progestogen. So the estrogen in this product, which is fixed, it's conjugated estrogen. It's a dose of Premarin, a lower dose of the sort of the highest dose Premarin that we used to use a lot of, and the selective estrogen receptor modulator bazodoxifene. So that's a bit like raloxifene, but this is the only combination of one of these products around, and it is very difficult to get. But it's very good for the places you want an estrogen to work, such as bone, etc., but it doesn't do the harmful things at the breast. And it doesn't also have the bleeding aspects associated with it. So you don't need to add a progesterone to this compound. It's not on the PBS, which is a consideration. It's appropriate if they're a year after stopping bleeding, so postmenopause. It's a low to mid-dose hormone therapy, and it might be quite a good option if they haven't tolerated progestogens in the past. But as I said before, it is not readily available. Micronized progesterone is worth talking about. The product name is Prometrium because that's important to know, because some pharmacies may compound this for you if you put micronized progesterone in it. But there is a product which has been rigorously produced to pharmaceutical grade standard and tested in women, and it's body identical progesterone. It can be added to any estrogen product. A continuous combined dose is 1 capsule every night. That's 100 milligrams. Sequential is 200 milligrams for 12 to 14 days per month, and I just usually say day 1 to 12 per month, and they'll have a withdrawal period after that. It's quite good for sleep and calming for mood. It isn't on the PBS, but it may be a good option when other progestogens haven't been tolerated. There's a lovely big study called E3N in 80,000 plus French teachers. It wasn't a placebo-controlled study, but they looked at them and they surveyed them over a number of years. The women on transdermal estrogen, and that was mostly a gel in that country, and micronized progesterone did not have an increase in breast cancer risk within 5 years of use, whereas they had a higher risk if they used synthetic progesterones. There was also no higher risk of breast cancer in oral estrogen or transdermal estrogen only in those women. So a consistent message about progestogen. But after 5 years, there is a slightly increased risk of breast cancer with that progestogen. It's the inconvenience of requiring 2 hormone therapy products as well, which can get complicated for some. So what type do you choose? I know it's very difficult. You've got a big job out there. You've got lots of things to think about, and menopause is probably a very small part of your practice unless you are focused on this. Based on the woman's history and other risk factors, if you're concerned about weight gain or breast tenderness or metabolic factors, VTE, etc., a transdermal approach, so a gel or a patch. There are special scenarios, and I will show you the Gene House Menopause tool, which is a lovely fold-out tool. It's available online through the Gene House website very freely, and you can see that there's lots of different scenarios like hirsutism, low libido, endometriosis. What types of hormone therapy would you choose in those scenarios? So we talked about scalp hair loss. You might look at the combination of estradiol and drospirenone, which is the product Angelique, Tibolone for low libido, and I usually, as I said before, start at the middle dose for the product and then can titrate up or down depending on their response. If a woman has had an adverse experience on hormone therapy or the pill previously, use the lowest dose. If it's premature menopause before the age of 40, a higher dose of estrogen as tolerated until around age 50, unless they can't have hormone therapy or the pill because they've had breast cancer or whatever. Potential side effects, I always tell ladies they might have bleeding if they have a womb still, or breast tenderness in the first 3 months. It usually will settle. That's why I see them at 3 months. I'm a bit sneaky there. I let the problems settle and then I see them after that. If there's bleeding that's ongoing, then I'll consider a change to sequential if they're on continuous hormone therapy. And when they're talking about VTE risk, a woman around 50 years of age has about a 1 in 10,000 risk of having a clot spontaneously. That goes up to 2 or 3-fold being on hormone therapy, so about 3 in 10,000 more with oral estrogen and not with transdermal estrogen. Women will worry about breast cancer. This is the biggest barrier to women taking up hormone therapy, and I think the biggest barrier to you prescribing hormone therapy, because you will worry that, oh, I've prescribed this and now this lady has breast cancer. I always tell my ladies between 1 in 8 and 1 in 9 Australian women will develop breast cancer over their lifetime, and that's irrespective of hormone therapy. So I have women in my office who have breast cancer, they've never been on hormone therapy, and some, yes, who've been on hormone therapy and have breast cancer. So there's a risk. If you're a woman, you're at risk of breast cancer. Hormone therapy is associated with a similar risk of breast cancer as consuming 2 standard alcoholic drinks per day. And the big major risk factors are having a strong family history and having dense breasts. So it's very important to tell women about that, just so that they can be educated about it and know about their risk. From the largest hormone therapy study to date, combined estrogen and progestogen hormone therapy increased that risk slightly after 4 to 5 years of use, and that was the WHI study that was originally published in 2002. That estrogen-only hormone therapy from that study, which was conjugated equine estrogens, was associated with a decrease in risk, and they went to 7 years on that study. So it's a very different story when we're talking about estrogen-only hormone therapy. As we mentioned before, the different progestogens do have a different effect on breast cancer risk, with those more natural progesterones having a much lower risk than the other ones from study data. And you need to talk about breast cancer and VTE and bleeding, and I will always write it in my notes and make sure if I'm writing a letter to the GP that the GP also knows that I've discussed those things with the lady. I usually will review at 3 months. I discuss the negatives, positives, bleeding, side effects, breast tenderness, etc. And a good thing might be to do a menopause score sheet before treatment and after treatment, and that can objectify things, because a woman will readily start forgetting her bad symptoms that she had before when she starts to feel normal again. And that's what we're aiming for with hormone therapy. Use I feel normal and my bothersome symptoms are under control. It might not be gone, but under manageable control is good. So there's a lovely menopause score sheet on the Gene House website or on the Australasian Menopause Society website. There's an individual menopause score sheet, but there's also on one with an information page, which is right at the bottom of our 30 information sheets, called What is Menopause? And it's very handy to just do the symptom score and then to see how treatment's going. I think it's very useful for some women. I adjust the dose at that point. I change the product if it's been a disaster, and then I will usually, if they're doing well, see them at 6 months, because my scripts will usually last 6 months, and I make sure that their screening is up to date. Ceasing hormone therapy annually, it's important to review why the woman is on hormone therapy. It's a good time to reduce the dose after a year or so, and the woman will quickly say, I'm having more flushes, sweats, or whatever, or oh, I'm doing quite well, and they can just start to withdraw their treatment. The studies suggest no difference between ceasing hormone therapy cold turkey or weaning, but I think it's always a lot kinder to reduce the dose very gradually and then just allow those symptoms to hopefully dissipate. But the studies suggest there's no difference. There is no ideal duration. Some women will be on hormone therapy in their 70s, 80s, and you'll always worry about them, but you've got to discuss with them that this is a matter of quality of life and symptom control versus the risks involved. And there's a nice information page, position statement by the North American Menopause Society called NAMS, and it's a one-pager. It's quite nice. You'll easily find it online, saying the pros and cons of hormone therapy for women over 65 years, acknowledging that some women will have symptoms that go on for a long time, and that hormone therapy might be the best option for them. I'm just going to talk about bioidentical compounded hormones. Women will come to you, it's very persuasively marketed, and they'll say, I want to be on this, it's safe, it's not pharmaceutical hormone therapy, so it's not going to put me at risk of breast cancer. But we don't know that. These are usually troches, which are lozenges dissolved in the mouth, or gels or creams that are custom compounded. We don't know of the safety, we don't know of the quality, we don't even know if they work. We need some study data. It might be a really good way to give hormone therapy, but we'd love to have some study data. None of the peak bodies, including the Australasian Menopause Society, support their use. And there's a lovely information page on Gene House for Women's Health and the Australasian Menopause Society that you can print out, hand it to the lady and say, I want you to be safe. If we're looking at hormone therapy, we need pharmaceutical grade hormone therapy that's been properly tested. And if they want bioidentical custom compounded hormones, you can say, well, I can definitely give you body identical hormone therapy that's the same estrogen and that's the same progesterone that the ovaries made, but it's pharmaceutical grade, perfectly tested, and I know about the safety and I can advise you appropriately for that. So Eva, as most women will want to do, and you will see this in your practice, she wanted to pursue natural treatment. So I talked about the pros and cons with her of black cohosh, which is used a lot in Germany, Europe, the UK, particularly in Europe, and is very useful for taking the edge off symptoms. But she had bothersome symptoms that persisted at a 3-month review, and we talked about body identical hormone therapy. I gave her an estradiol patch twice weekly, told her she can apply it to the tummy or buttock region and change it twice a week, so Monday morning, Thursday evening, and micronized progesterone was given every night. On 3-month review, she had scant bleeding only. She was quite happy that she didn't need to go to sequential use. She had a little breast tenderness, which settled in the first month, some patch site irritation, and I told her to rotate the sites, and that seemed to be useful. She had excellent symptom control and felt normal again, and we changed to daily estradiol gel and a micronized progesterone at that point, just because she had the patch irritation and wasn't really keen on the twice weekly dosing. I am going to hand it over to you. Thank you so much for having me. It's been delightful to speak with you about hormone therapy, and I will now be listening for your questions and I'll go through those as they come through. But thank you very much for listening.
Thank you so much, Sonia. Such a fantastic presentation again. We've got lots of questions coming through the chat box. First of all, I've got a couple of audio ones. Why does progesterone increase breast CA risk?
I've got a nice slide, which I didn't put in because I just thought it was better to be brief. But I've got a lovely slide which shows how the different progesterones interact with the progesterone and androgen and other receptors. And you can see very nicely from that slide that progesterone, which is micronized progesterone, drospirenone and dydrogesterone are very, very similar in the way they act at those receptors. But other progestogens, such as levonorgestrel, tends to act at other things like the androgenic receptors. So those ones are the ones in studies, and we think that that's the basis for the breast cancer. We don't know. It's very complex, but we think that that's one key, that the progesterones that are like the body's progesterone are actually acting at those receptors, and that's influencing the breast cancer risk.
Thanks, Sonia. Another question. I might have missed it, but what is the brand name of the micronized progesterone?
So it's Prometrium, P-R-O-M for Mary, E-T, Promet, R-I-U-M, Prometrium. It's just important. I know that it's very difficult for doctors at the moment because we used to be able to just easily prescribe Prometrium, but now our programs are designed to give us generics. And it's very difficult because I've printed out scripts that say progesterone and I've thought, oh, hang on, I want Prometrium, because some chemists have got that script and actually dispensed their own custom compounded progesterone, and there have been issues with mistakes there. And I had one lady who thought she was on progesterone, but she was actually dispensed testosterone, and the pharmacist did a big stuff up. So you just really be careful. I know when we have to do generics, but I would also specify if you want that body identical progesterone that's pharmaceutical grade, it's Prometrium.
Thank you. And one other question, I'll read this question out, but if you do have any other questions, please post them in the question box and I'll continue to read them. If a woman has BTB in the first 3 months of starting HRT, does that need to be LX given bleeding is expected?
So is that bleeding in the first, does that mean bleeding in the first 3 months? Is that right? Or
so women have BTB in the first 3 months of starting HRT.
Right.
Does that need to be Alex? I'm not, given bleeding is expected, I'm not too sure.
I think that's a question about if there's breakthrough bleeding in the first 3 months, does that need to be investigated? No, not necessarily. If they've been, because we're adding hormones back in. So if it seems like it's scant or whatever, if it's torrential and awful, yes, we investigate. If it's very unexpected, like if they've been postmenopausal for a long time and they're on a low dose of hormone therapy, that wouldn't be expected, yes, investigate. But it is normal within the first 3 months adding estrogen back in to have some bleeding. And as long as it's within that first 3 months and it settles, I don't investigate. But it's after that time, and if it's unexpected, etc., I would then at least do a very good quality gynecological ultrasound. But it might be that some women are perimenopausal and the breakthrough bleeding just means that they need to be on a sequential regimen as well. So just be very aware of that. And some women will come to you at 47 and you think, oh, they're postmenopausal, they haven't had periods for years, but they actually will be perimenopausal and still out of the blue have a period. So you can be a bit caught by those ones.
Okay, thank you. And name of estradiol gel.
So there's 2 estradiol gels. There is one that's been available for a long time that comes in a box of 28 sachets. It's called Sandrina, like sand in the sea, and R-E-N-A, Sandrina. That's the cheap one. They're tiny little dinky, it's like a tomato paste sachet. It's in a silver foil sachet. It's hard to titrate and use sort of half a dose, but 1 sachet applied to the thigh, it says to the lower body. You do need to rub that product in a lot. It is a good product. Some of my ladies really love it, but some find it very messy. And that's the PBS one, and it's just hard to halve the dose. But 1 sachet per day is equivalent to about an Estradot or an Estroderm MX 50 patch, so mid-range dose. There is a new pump pack, and if you're actually still looking, I'm going to show you that. I'm not saying brands, but this is how the pump pack comes in. Well, I am showing you the brand because you want to know the product. It's called Estrogel, and you just pump it onto the palm at night, and then you just wipe it from the hand up the arm. A low dose, which is good for that product, a low dose is 1 pump per night. It's not on the PBS, and it's called Estrogel, E-S-T-R-O-G-E-L. So now we have 2 gels. I do prefer this at night because it does need to be an hour clear of sunscreen or moisturizer, but it's a brilliant product. They last like a patch within the skin. They get absorbed within the hour and then they're active for the whole day. They won't wash off. So they're 2 very good options for the gels. Daily application.
Fantastic. Thank you, Sonia. We do have a couple more questions. Thank you. If patient is continuing smoking and has migraine, what could be the best option?
So the best option is to stop smoking and treat the migraine. That's a bit of a flippant response. But yes, definitely stopping smoking is a good idea. I'd be wanting to use transdermal hormone therapy. It just depends. It's sort of a cumulative effect. If they're obese, if they're a smoker, if there's a high family history of VTE risk, those sort of things, if their metabolic markers are awful, I'd always want to use transdermal hormone therapy anyway. The migraine side of things, yes, there is a lovely information page at the Australasian Menopause Society website and a beautiful webinar, actually, or a video that you can easily view on the Jean Hales website about migraine and hormone therapy. And those are very good sources of information. But again, with migraine, I'd probably be trying to use some transdermal form of hormone therapy, which is tricky at the moment because the transdermal combined estrogen and progestogen patch, which is a product called Estalis, has been in and out of availability over the last year. It's been very difficult, but that would be where I would be going for that sort of lady.
Okay, great. Thank you for a great talk. When do you investigate PVB? Do you allow 3 months for the MHT to settle in?
I think we've already had the convenience of asking that with our first question.
First question, sorry, I'm
That's
losing
right. No, it's the same. It's the same, just in a very different way.
Okay, great. Thank you, great talk. Sonia, do you see any role for testosterone use?
Well, funnily enough, I was going to put some slides in and I thought, do you know what? I won't. But I'm going to do another talk, if you'll be listening, next week, and I think I'm going to put those slides right back in. So the flippant way again of saying is you just have to tune in next time. But the non-flippant way is saying that yes, testosterone is good for some women for mood, well-being, libido, etc. There's a lovely consensus statement that I will present a slide on, which suggested it's extremely safe. The main side effects are things like excess hair growth, acne, etc. So more bother rather than an adverse, terrible event that puts them at risk. And the international sort of guideline has said the indication for testosterone use is hypoactive sexual desire disorder. That's low libido causing the woman distress, rather than those other things like cognitive benefit, mood benefit, well-being. But from my practice, I see that women on testosterone, when added to hormone therapy, have an improvement in mood and well-being. They feel better, and libido might improve if they're feeling better in their general selves.
Okay, great. I'm going to apologise for my pronunciation for the next question if I get it wrong. A lady in her 60s on Tibolone and wanting to stay on hormonal MHT, also at higher stroke risk as HX migraines with AURA. I wanted to change her estrogen, but very dense breasts, needing 3D mammography. Which do you think is the better choice for this lady?
So it's a really difficult thing, and I suspect she still has her uterus. So we're looking at estrogen and progesterone treatment together. It's about counselling the lady, and she might choose in the end. There's a lovely information page about Tibolone on the Australasian Menopause Society website. It's a pure page devoted to that. It is a slight increased risk in stroke from the 60s, and it's not an enormous increase, but she probably has other risk factors, especially if she's overweight and all those things as well. I'd probably try and use the lowest dose transdermal estrogen and progestogen together. And I think in someone like that, because Tibolone's already low dose, I'd probably be trying to use half of an Astalis continuous patch twice weekly. She could have one pump of the estrogel, for example, for the estrogen, and if she has a worm still, she'll need the progesterone, so Prometrium every second day if she's on just low dose estrogen. It's a matter of tolerance, quality of life, weighing up those risks, and sometimes the woman will decide and she'll say, I hate this thing, I felt better on the other thing, and then it becomes very tricky. But you've just got to advise as you can. Some of my ladies are still 70 and on Tibolone, and they've been pretty good on it.
Okay, great. Another question. Is it worth pre-treating perimenopausal women with DDB with progesterone Zoli first to reduce the risk of getting lots of BTB?
So Zoli's a really good option. So Zoli is the lowest dose combined oral contraceptive pill. It's also the one that's got the closest estrogen to the body's estradiol. It's very, very close, and it's got quite a kind progesterone as well. So that's a really good option for the 40s, and particularly the mid to late 40s. And it's really quite good for perimenopausal symptoms, which might start to break through despite a woman being on the pill in her 40s. So particularly with withdrawal bleeds and in the sugar pill, she might start to get in flushes and sweats and night symptoms, etc. So Zoli is a very good perimenopausal option. It provides contraception. It's a low dose, but it's good for perimenopausal symptom control, more so than the other pills for some women. And it's a really good step down from other pills to go to until around the age of 50. It's very useful for bleeding control in some women at all, because some women just don't have periods. So Zoli is definitely a very useful product in perimenopause, and hard to stop in some women who get to 50 and say, well, 50 is a number, why do I have to stop this product now, which has been very useful. And it might be further challenged by the fact that perimenopause can actually go for longer than age 50, so it might even happen for 1 to 2 more years. So it gets a bit tricky, but Zoli's a very good option.
Great. Also, do you have any concern with migraine and aura and estrogen use? I'm assuming you pronounce that aura, A-U-R-A.
You are pronouncing it very nicely. So that's where that Australasian Menopause Society migraine and hormone therapy information sheet is very useful. The pill, the combined oral contraceptive pill, has a much higher dose of estrogen and progestogen compared with hormone therapy products. So whereas we're worried about migraine with aura and the pill, we're not usually as worried about menopausal hormone therapy. Having said that, I'd always try and use transdermal hormone therapy first, or transdermal estrogen at least, if possible. And if the woman doesn't suit that, some will need oral estrogen, but there's lesser concern compared to the pill use in premenopausal women.
Great. Another question. They're all coming through. Well done, Sonia.
All good.
Just clarifying that it is okay to leave the Mirena IUD in for 7 years with estrogen as a progesterone cover.
So it's really tricky. I thought it was 5 years, so I'd probably just confirm that with your local gynecologist, etc., see if they're happy. The other thing is for contraception. So for contraception, it's 5 years. For hormone therapy use, my understanding was that it can be in there for 7 years, but you've just also got to be, aware about contraception as well. I have, however, seen individual gynecologists say, no, this can only be in for 5 years, so change it at 5 years. I suppose you can be better safe than sorry and change it at 5 years, but my understanding is that it can be part of hormone therapy for up to 7 years.
Okay. If a patient has sudden mental health issues after starting oral estrogen therapy, brackets, depression and anxiety symptoms occur, should you move to transdermal instead? How long should you wait?
So I think the main issue there is if they're around the time of perimenopause or menopause and having anxiety, depression, etc., it's probably due to the perimenopause or menopause. The hormone therapy, I'd still try and persist for at least 4 to 6 weeks before changing something, and hopefully for 3 months. It might be a factor of maybe Tibolone, for example, can be associated with a lowering of mood paradoxically in some women, and it's a funny product. It doesn't sort of kick in for some women until about 2 to 3 months into treatment, so that can be an issue. Women are all very individual. I'd be pushing for at least 4 to 6 weeks of use, but hopefully 3 months. And it's that sort of idea of having 3 cycles of something and allowing that to settle within the system. Women are very individual. There's no right answer. I've seen every sort of side effect under the sun. If they're unhappy on one product and things that are a lot worse, just need to take a different direction.
Okay, last question. If patient is on Microlat and Mirena for 5 years, age 53, how long can she go? Does not want to stop, so she'll get headaches, migraines, tired to stop for 3 months, frequency of migraine increased. How long can be continued?
So my understanding is, if I hear the question correctly, that she's on Microlut, which is her progesterone only pill designed for up to 50 years, and she has the Mirena in as well, which is a progesterone containing IUD. So she probably doesn't need both, and I certainly wouldn't have thought that she'd continue with the Microlut after age 50 anyway. I don't see a problem with the Mirena, but if she's had it in for 5 to 7 years, it needs to be removed or replaced, so be it. If bleeding's still going to be an issue, she's the sort of person that I would be referring off to get all of that sorted out again, because that story to me needs some work, and I think she's got into, it's like it's like an age thing. You do something at one age, and then if it works, you don't change it for a long time. But your body's got older, her arteries are stiffer, her wrists are different now, and she might have been doing that combination for years. I would give her the Australasian Menopause Society information sheet on migraine, menopause, and hormone therapy. I'd be looking at other options. I think that would be someone that I would be referring off to a gynecologist or an endocrinologist with menopause expertise for their recommendation. That's my gut feeling with that tricky question.
There is one more question if you have time, Sonia. Do you use Duovine, Duovive? What subset of women do you use this for?
So Duovive is a very interesting compound because you refer as a group to me, and I get the tricky ones because you're very good at the normal menopause and most of the tricky stuff. You do tend to refer me the tricky ones. So the tricky ones might have had every progestogen under the sun and couldn't tolerate it. So Duovive would be a good option for those women if they're having bothersome menopausal symptoms. They might, it's about tolerance. If they've got the money because it's not on the PBS, and if they haven't tolerated progestogens, again, that's where I see this role. I don't have many women on Duovive, but the ones I have had on it have tried multiple types of hormone therapy, and funnily enough, they've done quite well on Duovive, which the study suggests it's quite good for bleeding control. It's quite good for breast cancer risk. It's quite good for VTE risk, and etc. So it's a good option. They don't need the progestogen. It's all in one product, but it hasn't been available over the last year. I don't know if it's going to be available again. They've said July this year, but I suspect it's not going to be available at that time. But it is a very interesting compound, and if they haven't done well with other hormone therapies, that's usually where I will put that product.
Thank you, Sonia, and thank you so much for your time. We've run slightly over time. Thank you, everyone, for attending, and I'd encourage you to register on our website for the part 2 of this event, which is the postmenopausal issues, bleeding, bone health, and cardiac health. That one's occurring on the 18th of May. Also in our chat box, we have the link to our upcoming primary care refresher conference, which Katrina promoted at the start of this event. And everybody have a good night. Thank you once again, Sonia, and goodbye.
Thank you. Thanks for having me.
Thanks.
See you later.
Bye.
Bye.
See ya.
Bye.